Good afternoon, everyone. I'm going to talk about triple-negative breast cancer. And nothing to disclose today. I was given 20 minutes to discuss all of TNBC, so I think we will focus only on the new targeted agents that we have available over the past couple of years. We will start talking mostly about early TNBC, neoadjuvant, and mostly post-neoadjuvant therapy. So we will start with a question. We have a 38-year-old woman, BRCA wild type, who was diagnosed with a 4-centimeter clinically node-positive triple-negative breast cancer. PD-L1 is 0%. She received neoadjuvant therapy per KEYNOTE-522 and was found to have residual disease. What therapy would you recommend? You have no role for adjuvant therapy, Pembro, capecitabine, Pembro, or olaparib Pembro. I don't know if we can. OK, think of your answer, and we'll come back at the end, I think. So this is kind of my outline when I see patients in clinic with triple-negative breast cancer, how I think about treatment. And it obviously depends on the sites, lymph node involvement. And for this talk, we will mostly focus in this purple area that includes more of the immunotherapy and ADCs. And so for KEYNOTE-522 was a large randomized trial that enrolled over 1,000 patients with newly diagnosed TNBC. The tumors were at least 2 centimeters in size or node positive. And they randomized the patients to receive ACT plus carboplatin with or without pembrolizumab. Then patients went for surgery, and regardless of their response to treatment, then they received 9 additional cycles of pembrolizumab if they were in that arm, or placebo for 9 cycles if they were in that arm. And the primary endpoints were PFS and EFS. So you can see here the pathologic complete response rate that we know that it correlates well with long-term outcomes in triple-negative breast cancer. And there was a difference of 13%. Just note that only around 600 patients in this report were included. So when more patients were included, the difference was a little bit smaller, around 7%, but still statistically significant. Those data are not published yet. In terms of EFS, we also saw a statistically significant improvement with the addition of pembrolizumab. And when we try to break this down by different characteristics of the patients or the tumors to try to determine who could benefit from this treatment, we see that basically all subgroups benefited from this treatment, notably node negative, node positive, and PD-L1 negative and PD-L1 positive. So that it's great because a lot of our patients are benefiting from this treatment, but brings a challenge to clinic because how do we choose who gets it and who do we expose to toxicities? So this regimen was approved by the FDA in July of 2021 and is now the standard of care for most patients with high-risk early triple-negative breast cancer. Now, I just included the immune-mediated toxicities. I wanted to point out that around 20% of patients develop some thyroid issues, around 2.6% of patients adrenal insufficiency, and we see a lot of the other reactions that we see with immunotherapy, like pneumonitis, colitis, hepatitis. We tend to see a little bit more of these endocrine issues in our breast cancer patients. We don't really know why, but just a reminder to check thyroid function during and after IO therapy. And also, these are patients that are getting this in the pre-op setting. So if you're concerned about adrenal insufficiency, also consider checking cortisol prior to surgery. These are the adverse events in the neoadjuvant phase. In the adjuvant phase, the rates were a little bit lower. So this is great. We finally have some targeted options for our patients with triple-negative breast cancer, but there are still a lot of unanswered questions. One is, what's the optimal backbone therapy in terms of chemo? Do all patients need all that treatment? We were before thinking, do they need anthracyclines? Now everyone is getting anthracyclines and carbo plus the Pembro. Is that needed for everyone? I think for now, because that's the data we have and that's the way it's approved, many of us are using all of those agents. But I just wanted to point out there are multiple other studies assessing the role of immunotherapy in early TNBC, and some include anthracycline-free regimens. And I think it's important to know they are there because some of our patients are just not candidates for anthracyclines. They've had it before for other breast cancers. they have heart failure, so one could consider alternative anthracycline-free regimens for some of these patients. Another question that comes up in clinic, we know that patients that achieve a pathologic complete response have an overall better prognosis. So do they still need the pembrolizumab after surgery if they achieve the pathologic complete response? Again, that's the way it was done in the study, so I think most of us, or I at least, keep giving it after surgery because we don't know if there is a benefit. But this graph shows that the EFS for patients that did not achieve a PAT-CR, so the lighter green and red, there is a clear difference in outcomes if you continue the pembrolizumab after. But for patients who achieve a PAT-CR, that is the upper bars, the upper lines there is not clear that there is a difference, and you're exposing your patients to more toxicity and financial toxicities and just a longer therapy. So there is a trial that is being designed. It's called Optimize. It's going to be run by Alliance. The PI is Dr. Delaney, and they're randomizing patients who achieve a PAT-CR to additional immunotherapy or not. So we will be able likely to at least learn if we need it and potentially de-escalate therapy for the patients that achieve a PAT-CR. And on the other hand, what do we do for patients who did not achieve a PAT-CR? We know that those patients in general have a worse prognosis. None of the patients in the keynote study we discussed received capecitabine, and that's been standard of care now for several years for triple-negative patients. So what do we do with the CREATE-X data? And now we will talk in the next few slides about Olympia, but it was a study for germline BRCA carriers that received olaparib for a year if they had high-risk triple-negative breast cancer. So we don't know how to combine these treatments. We do have some safety data from capecitabine with immunotherapy and PARP inhibitors with immunotherapy. We do not have great efficacy data. A lot of those studies are single-arm studies, so it's hard to tease out if this is really the synergistic effect or it's just safe. But many people are combining this depending on the BRCA status because we think it's safe, and we might be losing an opportunity to treat these patients that we know that have overall poor prognosis. So going back to Olympia, was a large, almost 2,000 patients trial. They included patients with germline pathogenic or likely pathogenic variants, HER2 negative, and had high-risk breast cancer. They could have received treatment in the adjuvant or neoadjuvant setting. And just to point out the triple negative, for those that received neoadjuvant treatment, those who did not achieve a PAT-CR, so similar population as CREATE-X. And for those who received adjuvant treatment, patients with T2 or node-positive disease. And they were randomized 1-to-1 to receive olaparib 300 milligrams twice daily for a year or placebo. And the primary endpoint was invasive disease-free survival. So you can see here, there was a statistically significant improvement in disease-free survival. And there was a 3.7% absolute difference in overall survival. That's not yet statistically significant, but the data are not mature. And in the bottom, I'm not expecting for everyone to be able to read that, but virtually all patients benefited from this treatment. So it's just a reminder that now we need to also test for genetic testing our patients with early TNBC, because now we have to tailor treatment if they have a BRCA mutation. So this was approved in March of this year for this high-risk population, and the FDA did not specify number of lymph nodes. They kind of said high risk, so we have some space there to select a little bit about patients. So this is kind of going back to that schema for higher risk patients in that purple area. I think that's become standard of care to do neoadjuvant therapy. If the tumors are clinically 2 centimeters or larger or lymph node positive, then they go for surgery. If they achieve a PAT-CR, I will continue pembro or consider that trial once it opens. And if they have residual disease, I think doing the combination with pembro, with capecitabine or olaparib, it's reasonable, explaining the patients that we do not have those data, but we think it's safe, and it might be a lost opportunity if we don't do it at the time. So now changing gears to metastatic TNBC. We have another question. A 56-year-old woman who presents with newly diagnosed ER0, PR0, HER2-0, IDC of the left breast with metastatic disease to the bone and liver. Sorry for that typo. She had normal LFTs. Which of the following could you order to guide treatment? And just as a reminder, it's September of 2022 in the US. So these are all your options: PD-L1 with Ventana 142, germline BRCA testing, 22C3 with germline BRCA testing, 22C3 germline BRCA testing TROP2 IHC, 22C3 germline BRCA testing PIK3CA, Ventana 142 germline BRCA testing, and PIK3 mutations. So we'll come back to the couple of answers at the end. So this is how I break down when I see patients with newly diagnosed metastatic triple-negative breast cancer, and we will come back at the end. So KEYNOTE-355 was a randomized phase 3 study that included patients with newly diagnosed metastatic triple-negative breast cancer and enrolled patients only that were receiving first-line treatment. They were randomized 2-to-1 to pembrolizumab plus chemotherapy or placebo to chemotherapy, and the chemotherapy agents that were allowed were paclitaxel, nab-paclitaxel, or gemcitabine with carboplatin. And they received treatment until progression disease or cessation of study therapy. Here, I just wanted to show the breakdown. They included 847 patients, and they divided them, they stratified them by PD-L1 expression. They used the DACO 22C3 antibody for this, and they stratified them by CPS, the combined positive score, or more than 10% or more than 1%. And you can see that in this study and other immunotherapy studies, around 30 to 40% of patients are PD-L1 positive, depending on the assay that it's been used. So we have the PFS data here that show that in the intention to treat population, there was an overall improvement, but the ones that benefited the most were the ones with PD-L1 expression of CPS more than 10. And there was the hazard ratio is 0.66. We recently saw the overall survival data, and we saw that in the pembrolizumab group, the median overall survival was 23 months compared to 16.1, and I think this is remarkable for metastatic TNBC. We have not seen these improvements with other agents. In terms of toxicities, kind of similar to what we discussed before from KEYNOTE-522, with around 20% of thyroid dysfunction and the other common immune-mediated toxicities. And this was approved in November of 2020 by the FDA. Now we're moving to another exciting area out of immunotherapy, to antibody-drug conjugates. And just as a quick reminder, on the top right, you can see an ADC. Here is sacituzumab govitecan. You have a monoclonal antibody, and it has a linker to a cytotoxic payload. In this case is SN38, which is similar to irinotecan or active metabolite. So it's a kind of smarter way to give the chemotherapy and target the tissue that expresses this target. In this case, it's TROP2, and we know that most TNBCs express TROP2. So the ASCENT study was a phase 3 trial that assessed the role of sacituzumab govitecan in triple-negative breast cancer. Patients received at least 2 prior lines of treatment, and the patients were randomized 1-to-1 to sacituzumab govitecan or chemotherapy of physician's choice. The primary endpoint was PFS. And you can see here there was an improvement in PFS and in overall survival in patients without brain metastases. And again, virtually all patients benefited from this treatment. So this was approved in April of 2021 for the treatment of TNBC patients who have received at least 2 or more prior lines of treatment. In terms of toxicities to consider, neutropenia is common. So many people are using growth factors with these agents, especially because you give it on day 1 and day 8. So sometimes you want to support them so you can give the full treatment. GI toxicity, similar to what we see with irinotecan, and alopecia is also seen. And finally, I have a few minutes to talk about HER2-low, which we all got really excited during ASCO this year to finally see the results from DESTINY-Breast04. So to start, what is HER2-low? So we traditionally thought about HER2-positive, IHC 3+ or 2+ with fish amplification. And prior studies with trastuzumab showed that there was really no effect of HER2-targeted agents on patients with HER2 negative. But now that we have more potent and directed therapies, the question came again. And in this study, they included patients with HER2-low breast cancer, so IHC 1 or 2 plus, not amplified by FISH. We know that it varies a lot with the studies, but around 40 to 60% of patients with HER2-negative breast cancer have HER2-low expression. So it's a very important question because it affects a lot of our patients, right? So DESTINY-Breast04 was a phase 3 study in which patients with HER2-low metastatic cancer were, after 2 lines of treatment, were randomized 2-to-1 to receive TDXD or chemotherapy of physician choice. The primary endpoint was PFS. Since we're talking about triple-negative breast cancer, I wanted to point out here that around 480 patients in that study had hormone-positive HER2-low, and only around 60 had hormone-negative HER2-low, so our typical TNBC. We can see here the all-patient and the hormone receptor-positive cohorts. There was a statistically significant improvement in PFS of around 4.7 months. There was also an improvement in OS of around 6.5 months, again, in the intention to treat a hormone receptor-positive population, which was the biggest number of patients in this study. When we look only to the ER-negative population, there was also a benefit. The benefit in PFS was 5.6 months and overall survival of 9.9 months. And again, we have to think about these patients previously treated at least 2 lines of treatment, and the options are usually not good. So with these ADCs, we're getting new targeted agents that are really promising for these patients. And in terms of toxicities, nausea is very common, neutropenia, hair loss, and I think nausea is a particularly one that we have to be aggressive with treatment with our patients. And these slides were done last month, but they are already outdated. This is now approved as of last month for the treatment of HER2-low breast cancer. The FDA was not specific about the hormone receptor status, so I think that's a great thing. We have another option for our patients. So going back to this, so when I see a patient with newly diagnosed TNBC in clinic, I always send PD-L1 first. Since we only have pembrolizumab approved, I'm only sending the 22C3 the assay. And then if they have PD-L1 positive disease, so more than 10%, I would start with chemoimmunotherapy. If they don't, you can start either with chemotherapy or with a PARP inhibitor in the small percentage of patients that have BRCA mutations. So we need to remember to test our patients send them for germline testing. And then after 1 or 2 lines of treatment, I think it's when the ADCs and the HER2-low question comes. So we have to go back, and I've been going back to the pathologist, ask them to check again if HER2-0 or HER2-1 was really, because we were not paying attention to that until now. And there is a lot of inconsistency between HER2-0 and HER2-1 expression when reviewed by multiple pathologists. So I've been asking them, are you sure this is not HER2-1 plus? And sometimes it is, and it opens the door for another treatment for our patients. So I think after that, if you have HER2-low cancer, you can consider sacituzumab or TDXD. We have no data comparing them or in sequencing. So I think the big caveat here is that we had 60 patients in the TDXD arm, but the outcomes are really impressive. So it's, I think, a discussion with the patients. I did not mention the toxicity of TDXD of interstitial lung disease, which is always a concern. So if you have a patient with interstitial lung disease, you might want to give sacituzumab. If you have a patient that lives far away, that TDXD is only every 3 weeks versus saci that it's twice and then 1 week off, maybe that's when you give TDXD. I think it's a discussion with the patient, and it's great that we're getting to a place where we have options for these patients. And of course, after that, consideration for chemotherapy. Clinical trials should be at the beginning of this, but of course, we many times start thinking about it later. And if they have HER2-0, sacituzumab will be the first ADC to go, and then chemotherapy or consideration for clinical trials. So going briefly back to our questions. So for this patient who had node-positive residual disease after the keynote regimen, I would consider capecitabine with pembrolizumab. She did not have a germline BRCA mutation. And for this patient, we used to use the Ventana 142 antibody assay when we were using atezolizumab. Now it's no longer approved, so I'm just sending the 22C3. We know that these assays are not always consistent, so when possible, I try to get the one that was approved with the drug, which in this case is 22C3, and germline BRCA testing. There was some data about IHC testing for sacituzumab. We know that most tumors express TROP2 and most patients benefited, so there is no role for testing. And PIK3CA mutations are at this point, there is no drug approved for triple negative disease. And I think we're very late, so I can take questions afterwards.
You can address those two questions that are virtual if you'd like.
Is there any way to predict or assess the likelihood of PCR prior to surgery for those who strongly wish to avoid surgery? Could you argue that patients who achieve a PCR hypothetically might not require surgery? So I think those are great questions. I think we're not there yet. Some studies are trying to assess that. I think we will start probably with tumors that have more targeted options. So if you have a PCR after HER2 therapy and you will continue your HER2 treatment, I think that's, or hormone positive, that it's unlikely to have a PCR. But if you have more targeted options longer term, that may be the first steps. But I think at this point, I will not omit lockout therapy.
Thank you so much.